Welcome everybody. I see some people are still flowing in, but we are going to get going because we think this is going to be a very exciting and energetic hour. It's not a traditional format. It is a debate, even though I believe it is going to be a gentlemanly debate. But I'm hoping that with your participation, we can maybe take the gloves off and get a little bit, maybe like the Republican debate the other night. It might get a little bit more exciting. So, and that is serious. We do want your participation, so please be thinking of questions that are much more hard-hitting than the ones that I'm going to be asking. I'd like to introduce our two debaters. To my immediate right is Shahid Shah, who many of you know as an internationally recognized and influential healthcare IT thought leader. He's a blogger. He's known as the healthcare IT guy. He's a CEO of MedStep. And what you may not know is he's really worked in IT for over 20 years. He's helped design and deploy the American Red Cross electronic health record solution. He's built 2 web-based EMRs now used by hundreds of physicians. He was the ex-CTO for a billion-dollar division of Cardinal Health. And he's also a senior technology strategy advisor to the NIH, to their SBIR and STTR programs. So we're very happy to have Shahid here from DC. And then sitting next to Shahid, we obviously all know Joe Kvedar, who is the founder and director of the Center for Connected Health. And thank you for this conference, Joe. Joe, as we all know, is sort of the father, in my mind, of Connected Health. He has really worked to leverage information technology, cell phones, computers, network devices, remote health monitoring tools, et cetera, to engage and to really work on clinical outcomes. And what you might not know is he's the co-founder of Healthrageous, which was spun out of the center in 2010. Joe is the author of so many publications, over 70, and he is sort of an international bon vivant who does lots of lecturing worldwide on the subject. So I think we've got a very capable group here with Joe and Shahid, and we're very much looking forward to hearing their remarks. What we're going to be doing now is talking about a very interesting subject around patient self-care. And so what I wanted to do is to, first of all, define what patient self-care is so that when we're talking about it, we're all on the same point. So I don't know what just flew over there. So when we talk about patient self-management, in 2003, the Institute of Medicine defined it as the systematic provision of education and supportive interventions by healthcare staff to increase patients' skills and confidence in managing their health problems. And this includes regular assessments of progress and problems, goal setting, and problem-solving support. So what are the things that we're talking about when we talk about self-management? We're talking about engaging in activities that protect and promote health, monitoring and managing symptoms and signs of illness, managing the impacts of illness on function, emotions, and interpersonal relationships, adhering to treatment regimes, providing information and education, and engaging in collaborative decision-making. And what are the tools? I mean, we're going to be talking about these tools all through the next 2 days, but when we talk about subordinate tools that provide limited patient discretion, video monitoring and home surveillance sensor systems come to mind. Structured tools or more active self-management. Those are things like sound and text reminders from household appliances, personalized or personal digital assistants, telephones, devices that allow patients to transmit data such as blood pressure readings. A third category is collaborative, which covers tools that have been the ones we talk about the most. These are decision support aids, online interventions, chronic disease management aids, patient education materials, and then autonomous. So internet sites such as eDiets and home heart defibrillators. Again, we're all very familiar with these tools, and what we're here to talk about today is, are these tools and the notion of self-patient management actually doing what we think they should be doing, reducing costs and increasing quality. And when we talk about reducing cost, we're talking about inpatient days, hospitalizations, those types of things, admissions. And then in terms of higher quality, are they improving clinical outcomes, and are patients enjoying better quality of life? So hopefully we're going to get to some of those points right now. And I think I just want to turn it over to Joe to just say a quick word before we flip the coin and get going.
Thank you, Cindy. I just asked to go off script for a moment to take my first opportunity at the podium to enthusiastically welcome everyone here. It's a privilege to convene this conference every year and see it grow in size. We're, again, up about 10% in attendees this year from last year, and it's just a thrill to be able to be part of it. And I also just wanted to take my opportunity before we go on to our timed remarks to thank several people who helped me prepare, from the Center for Connected Health. Stephen Agbula, Ms. Mohammed, and Gina Cella were helpful to me, and my colleague and friend Gary Gennard was also helpful to me in preparing for this debate. Thanks.
Joe, that's the only time you're allowed to go off script. We're now going to be in a highly managed time situation, and what I'm going to do now is read the resolution. And I'm going to ask you, how many of you agree with this resolution? That the current approaches to patient self-management do little to improve quality or lower costs. Can you please raise your hand if you agree with the fact that the current approaches are doing little to improve quality or lower costs? Okay, what did we say, about a quarter? Yep. Maybe? A quarter-ish? Okay, interesting. Okay, we'll keep those, remember how you voted, because we'll come back. And now, because this is an official debate, I am going to take a coin that flew on the shuttle, and I'm going to flip this coin, and depending on where it lands, this will determine who goes first. So this is very high stakes. Joe, would you like to call, you either call the shuttle head or the back? What would you like?
Heads.
Okay. Let's see. I hope that if it shatters, I apologize. Okay. Heads. Joe. So Joe now gives a 5-minute opening remark, and then he'll be followed by Shahid.
Does this mic work as well? Or no? Okay. Well, I'm here to argue enthusiastically that, of course, patient self-care can lead to improved quality and lower costs. The key to the debate is the term current practices, and I'd be hard-pressed to argue that practices of 5 or 10 years ago, say a diet self-help book or a handout you got in your doctor's office, would actually impact in a positive way cost or quality. But this is a connected health conference, and with the tools we have at our disposal today, the tools of connected health, I'm quite confident I can convince you that self-care can improve quality and lower cost. It's based on the following logical premise. Self-care, connected health can lead to improved engagement. Improved engagement will lead to improved outcomes, and improved outcomes will lead to lower costs. Let me share with you, frame it by sharing with you a prototypical patient from our connected health programs. Now, the experience of this model patient is an experience that we and those of us who work in the connected health programs at Partners experience on a daily basis. Rachel's a 54-year-old woman. She has type 2 diabetes. She's about 20 pounds overweight. And sadly for her, she's just been told she has to go on insulin. And this is not something anyone wants to hear. But her doctor also says she can participate in a program where she uploads her glucometer readings twice a day and is able to see her results in context on a website and get periodic updates from her, a nurse in her doctor's practice. Now, as she does that and experiences that, the first insight she gains is that if she doesn't test her glucose, the nurse notices and asks why. And this sets up this cycle of accountability and learning and just-in-time teaching that's so powerful in connected health. And so her health care becomes top of mind. Her glucose readings and her lifestyle become top of mind. So she digs deeper into the website and she sees that she can actually do some lifestyle alterations that will improve her quality of care. And she starts to track her activity on her own with a pedometer. And within a couple of months, she's lowered her hemoglobin A1C by a point and lost 10 pounds. This is not, I'm not making this up. This happens in our programs all the time. And indeed, in a population of diabetics that we studied, we found that engagement as measured by uploads, by frequency and start of uploads of glucose readings, was correlated with up to 1.5 points drop in hemoglobin A1C. Now, why do you think we saw these outcomes? It's because connected health can lead to improved engagement, and improved engagement can lead to behavior change. Behavior change, in turn, will lead to lower cost and improved quality. Let me just offer a couple of other examples from the literature. I'm pulling from the telehealth literature because I'm making the assumption that telehealth programs have at least part of their success through improved self-care. And I'll call your attention to a study that was published recently in Health Affairs, where individuals, Medicare patients on the Health Buddy system, achieved a $542 per person per quarter savings using that health appliance in a telehealth program. And I'll also call your attention to a study from Great Britain called the Telemonitoring and Self-Measurement of Control of Hypertension. So again, a self-care hypertension management program that achieved a drop in systolic pressure of 5.4 millimeters of mercury in the experimental group compared to the control, which really equates to a 20% reduction in risk for stroke and a 10% reduction in risk for acute MI. So I could go on and on. I'm reaching the end of my time, but I am enthusiastically in support, and the literature supports the concept that self-care can lead to improved quality and lower costs.
All right. So the big question is, am I the right person to take this position? Primarily because I'm not a Luddite. I carry a Fitbit, for God's sake, right here, right? It's a self-care device. I'm usually starting companies in this area. I'm an angel investor in these areas. I advise companies on how to sell products in connected health. So why am I taking this position? Ultimately, it's because I'm a scientist and I'm an engineer first. We have to have concrete evidence that, not anecdotal, not small case studies, but writ large. If you think about healthcare in a particular state, within a particular country, in the large scale is our big question. So the reason I'm taking this particular position is that Joe T., the guy who you saw introducing us the other day, a little while ago, and I spent a lot of time in Denmark about a couple of months ago reviewing health IT companies over there, and I was one of 3 consultants invited by the embassy to say, are our companies doing well enough to where we can take Danish health IT into the United States? And as we did a lot of research, we tried to explain to them, here's how the U.S. works. We're big on ROI. We're big on evidence. We're big on this. It became pretty clear that while connected health makes a lot of common sense, there's still a lot to be gained with respect to actual evidence and actual studies that need to be done to prove these positions. So right now, I feel like we're in an eminence versus evidence debate. We have people like us who are telling everybody else, hey, this is what we do. This is why connected health is good, and you should go do it. And because of that, I spent $120 on a Fitbit. Unfortunately, that's our evidence today. It's based on, we think it's a good idea. That's eminence, in my opinion. The evidence side is where I think we're lacking. And in fact, I have the easier argument in this case, because there just isn't, there are definitely pieces of literature that are talking about very small areas, slices of evidence that we have, but broad-scale, wide-scale impact studies haven't been done yet. So just yesterday, we saw a report in the Wall Street Journal about CMS doing an analysis of 55 million patients, elder patients over the last 10 years. And now we see that those studies have indicated a 30% decline in hospitalization of patients with heart failure. We don't know why there was 30% decline. If we were to say that the 30% decline came because of X, we'd have to define what X is. And so that's really the position that I'm taking is, why did it happen? And we could say that it was because of technology, it was because of certain drugs, et cetera. But the answer is we just don't know. The guys who ran the study said they don't know. They saw a decline, but they don't know why. So I want to start the conversation off by just thinking about some other industries. And sometimes when you're having a debate about a particular topic in industry A, it makes sense to talk about other industries as well. So think about the travel industry. If we would have said 15 years ago that everybody, no, I shouldn't say everybody, most people make their own travel arrangements. You can get your own ticket online. You can go and check in online. Would we say in those conditions that we want to do all this because it'll make the plane safer, or that our service would be better, that we're going to find a better on-time performance of aircraft? Those are things we would have said 10 or 15 years ago if we said, let's plan this out in some way to say we want this to happen. That's what we're trying to do here, is to say, well, should we do connected health specifically for outcomes and get that evidence, or should we do it because it's, quote, the right thing to do? Eminence versus evidence. So if you think about the planes, I mean, it's not like we had a 3-hour delay yesterday. Yet I checked in online. I did everything that I needed to do, but I still had a 3-hour delay yesterday. The customer service is no better. I pay more for my bags today, and we're all online, right? Now, think about bank accounts. Are the bank accounts any cheaper today, even though we can get direct access to them? We're happier. Absolutely, we're happier. But it doesn't mean that the outcomes that we're looking for, that the actual detail that we want out of those, if you say that if you are online and you are connected to your bank, fully engaged, you're going to make more money, that you're going to have lower bank fees. You're going to have all kinds. Just think about how we equate the banking and travel industries with healthcare, and you'll start to see that we're not necessarily looking for the right things. We're trying to measure the wrong things. And so if we're going to think about this in a large scale, we have to say, what are we looking for? So I often teach in I teach entrepreneurship classes and these commercialization reviews that I do for NIH and Tatrick and others. I tell people to think about 3 things. When you're thinking about selling something, think about the payer, the benefiter, and the user. If you can take the person who pays for something, the person who benefits from something, and the person who uses it, combine them together, that's going to be successful. But here we still have cases where the payer is different for whatever we're doing. The benefiter is different, which may be the physician getting additional data, which might be the patient getting additional data. And here the user, we're assuming we're going to put more work on the user here, which is the patient, and that becomes a little questionable. How do we do that? So ultimately, I believe that what we're talking about with respect to our particular resolution here is not patient self-management. That's an oxymoron. If you're a patient, you're not really self-managing anything. You're the patient, and there's a directed manager of you. That director is a healthcare provider of some sort. And so directed management, facilitated management, prescribing tools, prescribing education, that's the kind of stuff we're talking about. And if we are prescribing a tool, if Dr. K is going to prescribe a tool and prescribe an education, that has to be something that we should get some evidence behind, have some output from the outcome side to be able to clearly demonstrate that we have, in the end, what we were expecting. So again, think about it and say, just like 10, 15 years ago, the airline industry, if they would have promised us, no more delays on the aircraft, better service, more food, no bag checks, etc., we would have loved it. We would have said, yeah, let's jump on. But we are now all online. We are fully connected, fully engaged, and it didn't necessarily make that travel any better, any safer, etc. And that's the way to think about this argument.
Thank you. Two excellent opening remarks, and you can see they both feel pretty passionately, or at least arguing pretty passionately their sides. So we're going to start with the first set of questions here. And like I said, please be thinking of your own questions, because I'm having a feeling mine are a bit softball, and I'd like some hard-hitting ones from you. I'd like to start with Shahid. When we first polled the audience, it was only about a quarter, or even less, that agreed with your position that current techniques are doing little to improve quality and costs. How do you react to that?
I was a little bit surprised. Is this on? I can't see this.
Let's see. Is it working?
This one is. Okay. Yeah, that's one. It's on.
Oh, it's on now. Thanks.
We're only giving Joe the mic.
Yeah, only he can talk. He's the boss. All right, so I wasn't too surprised in the sense of the numbers were low, because again, healthcare runs so much on eminence, and there's a lot of us, standing up on the stage. At any other conversation or any other conference, I would be on his side, right? Because these are things that we think is just the right thing to do. And when you think about the right thing to do, well, it would be insane to say, well, patients shouldn't get more control. They shouldn't be doing more on their own. But again, doing that in a structured, directed, prescription-oriented way, which is really what we're talking about when we say patient self-management. If you're saying, I just want to, have good advice given out to people, that's fine. But if we're giving directed advice, directed things from caregivers, that's a little different. So yes, I'm not completely surprised, but hopefully by the end of this conversation, we'll make some changed minds here.
Joe, a 1-minute rebuttal.
Wow, where do I start? I guess there's plenty of evidence. So I would call your attention to the Cochrane library, which I think we'd all agree is one place where, those of you who aren't familiar, but that's sort of where people put large studies and meta-analyses and sort of formulate the evidence. And a particular one that struck me was a self-management. This is, again, meta-analysis of outcomes of self-monitoring and self-management of anticoagulation therapy. And the conclusion was that self-monitoring and self-management of anticoagulation therapy has showed a 50% reduction in both thromboembolic events and 34% in all-cause mortality. I guess that's improved quality. So I think there's plenty of evidence. People who gather evidence always argue that there isn't enough evidence because they make a living gathering evidence. And so, every paper at the end of, if you read every scientific paper, it always says at the end, more research is needed in the last paragraph. It's true. I mean, it's a self-perpetuating thing. Now, and I would be also happy to acquiesce that the evidence isn't perfect, but it's there. Now, in our own group, and this is perhaps unfair because we're just getting the paper in review, but we showed in a self-monitoring program for hypertension, and it really was self-monitoring. It was people measuring their own blood pressure, looking on a website, and getting automated feedback through that website, that they had a 10% reduction in systolic blood pressure, 10-point reduction in systolic blood pressure, 5-point reduction in diastolic blood pressure over a 6-month period. So no question that self-management has evidence behind it.
Well, we're continuing to talk about evidence, and I'm wondering if we need to define what evidence really means, because you obviously are talking about it differently. So Joe, can you really say that there is hard evidence supporting your position, or is it more anecdotal, small pilots, small sample sizes? Is there really hard evidence to support your position?
Well, what I would say to that is let's not delude ourselves that randomized controlled trials are reality either. If any of you have ever been a participant in a trial or run one, you know right away that you're way off reality when you run those things. We, first of all, recruit people, so right away we're getting people who are motivated enough to come in. Secondly, we remind them for 6 months that we're studying them, and then we pay them to participate. So how is that reality? And now I'm scientifically trained. I fully appreciate the idea of control groups and whatnot, but just let's not delude ourselves. It's simply a way of looking at the world. It's one way of looking at the world. And one of the things that a number of us in the industry are passionate about is trying to figure out a way to measure things in the real world, because we also know that before and after studies are fraught with problems, as you alluded to, this giant regression of the mean in heart failure. Yes, that's there. I'd say in any given sample, including our own, when we looked at it objectively using control groups, we found that our intervention made a difference. In our case, 50% reduction in hospital readmissions over time for an intervention that relied heavily on self-care. So, again, I think evidence is a tough term to define. What's enough evidence? I can't tell you what enough evidence is.
Shahid?
Yeah, so I think that ultimately when we're thinking about evidence, the way to really think about it is, especially folks within this audience, and many of you are probably either building systems, buying systems, et cetera, you have to make sure that those systems understand that evidence needs to be captured. So there are ways of, we're all focused around meaningful use these days. We know in general meaningful use was, step one of 100 steps that need to be taken. But one of my biggest problems as I'm teaching, startups and other people building these kind of tools is, what are you building in to where you know that things are getting better? So the premise of this resolution is in two places. Outcomes, which one can say is either health quality, improvement in life expectancy, et cetera. There are a few of these that we can define pretty well, or a reduction in cost. If you can show either, I'd be happy. The problem is that in general, most of our systems that we're building don't have enough data to be able to capture what happened beforehand and what happened after. And I completely agree that, I'm not saying that we need to have a clinical trial FDA style for every piece of software that we write, but the systems that we're building, when we have caregivers directing specific types of tools, techniques, et cetera, you just have to have a much higher bar than if you're just saying, go read a book about something, right? That's really what the argument here is. So when you say evidence, the evidence has to be something that is being built into our system. So you have, for example, the new national quality model that was just released by the National Quality Forum a couple of days ago as a starting point. You take the quality model, you build those into your systems, and then you're tracking associated patients with directed, and I'm not going to call it self-management necessarily, but directed tools and directed education, prescribed tools and prescribed education versus non-prescribed and non-directed, and see what happens. And if your systems, if you're in the electronic side, if you're in the health IT side like I am, and you're not building those in to be able to prove it, then we're not doing some of the basics that we need to do.
Rather than go to the next question, Joe, you were nodding your head as Shahid was just talking. Could you comment on what he just said in terms of your response?
Only the nodding was that one of the powers of systems, and particularly connected health systems, because we're gathering physiologic information on an almost real-time basis, is that we can collect enormous amounts of evidence that we heretofore have not dreamed of. So that was my sort of evangelist hat that I had on at that point.
Okay. I'm going to go to, instead of asking my next question, I'm wondering, does anybody in the audience have a burning question? Right, right, that was the first hand I saw. Do we have mics for the audience?
Yeah, sorry, forget the mic, I'll speak up.
Okay.
I'll make a general statement to start with to say that I think one of the biggest concerns we've got is that a lot of people have lost confidence in hospital and hospital treatment and are pushing treatment back onto the individual. But that's not my point. My point is that it's great that people can stand up and talk about generalities. But I'll give you one example where care costs are exploding. If you are cognitively impaired or you have dementia, there's 5.8 million people in America with that condition.
I didn't see a question there, but let me actually turn over to our debaters here. Do you agree with that? And how do you respond?
Well, the gentleman is a powerful speaker, so hats off to your speaking voice and your passion. But I didn't quite understand the thread, so apologize for that. But I guess on the one hand there is evidence, but it doesn't work in the home, so I guess I'm kind of confused. And by the way, specifics, so I talked about diabetes specifically, hypertension specifically, and heart failure. I don't know how much more specific I can get. Dementia isn't one that we've studied at our center, so I can't comment on that.
Yeah, I think the broad statement that he was making, as I understood it, is that there are things that we do in a critical care facility like a hospital, and then assume that those same things, if done in the home and carried into the home, might work just as well without the caregivers being nearby. And that is something that we, for example, in our startups that we work with, lots of them want to start in this area is, hey, if I could just move this care from a critical facility to a non-critical facility or to the home, or in the case of rural environments where you can't get the care, it's got to be better just by putting it into the home. And common sense-wise, that makes absolute sense. The problem is if we say that it's a directed care, if a physician said, go use this tool upon checkout at the hospital, that's completely different, and we need to do just a little bit more, if not necessarily a full trial set, but we have to understand that next escalation of a physician directing something means something more to a set of patients than someone else just mentioning that. And I think that's really the key that I think he was mentioning, is that simply saying that the same thing that you do at the hospital when moved into the home might be just as good may actually put you in a worse state because now at home you don't have the caregivers watching you deteriorate, et cetera. Numbers are numbers, and we even for the next 5-10 years, we're not going to have the complex event processing systems that need to look at this data as on its way in that's streaming, and without that, we're not going to be able to interact and react in the way that a caregiver would in a critical care facility.
All right, so let me I'll come back to the audience in a minute. So to that point, to take it to the next step, Joe, isn't there a great potential for self-harm if we let people take control of their own care? Forget about the cost side. Let's look at their own care, their own health.
Well, let me give you an example. We have a program at our center we call MedStep. It's an extension of the hypertension program that I alluded to earlier. So the way it works is patients have a blood pressure cuff. They have the same rich website on which they can view their readings and trends and so forth, and then there's an opportunity for them to give some feedback on that website as well. So that's the sort of standard package. What we do in MedStep is we give them also algorithms on which they can change their own medications according to their blood pressure readings, which is pretty daring when you think about it, and pretty, I would say, leading edge from a self-care perspective. I'm happy to report that in our initial sample, so yes, it's not a 5,000-person trial yet, but in our initial sample, nobody got hurt. People did just fine. They were much happier with their care, and they had a significant lowering of their blood pressure with a p-value of 0.03. So it's an example. It's a start in that area.
Great. Shahid?
Yeah, I would just add 2 seconds worth is that Partners is doing exactly the right thing in order to gain that minimal level of evidence. So when a physician at Partners says, go do X, it's because there's been enough research behind it. They have the resources, they have the mechanisms in order to make that happen. Of course, not everybody is a Partners. Not everybody is an Intermountain, and that's what we need to watch out for as connected health professionals here, is that we are in a special group of people, like-minded. We're here at an advanced academic-oriented environment, and that ain't the rest of the world. And so that's what we need to help make sure that we cover what isn't in the rest of the world.
Great. All right, back to the audience. And can I please request that you ask a question? All right. I actually saw your hand first. Go ahead.
Yes. When you asked the question earlier, I was sort of torn whether or not to raise my hand, because my feeling is that the studies and the evidence is appropriate to say that it works when applied, but we've been trying to bring about a statewide, we're trying to expand this throughout our state. And what we've been finding is difficulty in uptake with the general population when you're taking this out from your highly motivated people. and also from some of our providers not knowing how to fully utilize these tools. And so my question to you guys is, how do we expand from the controlled environment of the studies that demonstrate the evidence and expand that out to the general population of an entire state?
Can I take that first?
Sure.
All right. So a quick reply would be that, you know, from my side, my suggestion is if you can show value, as opposed, so evidence is definitely important, but if you think about the way doctors are picking up iPads, or that consumers are picking up their handhelds and iPods, etc., you can see that they're chasing value. They're not chasing evidence. So as we showed this, and the physicians that are picking this up really rapidly are the ones that can see value, but that comes from eminence-based transition, where smart guys like him are telling their fellow doctors, go do this. And many of the ones that are affiliated with other smart doctors are doing it, but the vast majority cannot, because the systems, while they, even in these small slices of evidence, can't demonstrate the evident value that the customers expect, which is where my problems are. So when we're starting companies and we want this widely accepted, those numbers just aren't there, and that's what we need some help producing.
Yeah, I truly sympathize with your question. As moving projects from concept to scale is something that we've really studied over the 17 years I've been doing this, and believe me, all the answers aren't in yet. But I would say a couple things. The biggest barrier to innovation in care models is fee-for-service reimbursement. And so if that's the kind of scenario your state is in, God bless you for doing as well as you did, because you're using tools that take patients out of the brick and mortar, which is where the money flows. So we're just really excited, those of us who are connected health evangelists, for the time of bundled payments, shared savings, all these new models that are coming, because, and I can already see in our own population of physicians the change in thinking and the willingness to look at alternative care models when you take the shackles away of fee-for-service reimbursement. So I think on the provider side, that's the way to tackle that is, number one, have your quality numbers handy, just like a drug rep always does. Yes, these studies showed this and that and the other, and our pilots showed this, that, and the other. But number two, and this is how you're going to be able to leverage this in a new reimbursement environment and change your workflow accordingly. On the patient side, we all struggle with those people who prefer to be couch potatoes and not get off the couch. And I'd be the first to admit that that is the holy grail. And I think that that's where the partnerships with our health plans are so important, because they have the leverage with their employers to say, you know what, you feel free to go out and destroy yourself, but we're going to charge you a higher premium. It's okay. And people do respond to that. So I think that's when the sticks come out, not just the carrots.
Well, let me just follow up to that, Joe. So if you have patients that are not motivated, that aren't going to participate, is your answer penalization, financial penalization? Is that the answer?
Well, I think that's one very blunt instrument that can be applied. And if you look at certain companies, the way they're handling non-smokers and smokers and so forth, you're already seeing it in the marketplace. There of course, are other tools, and there are choice architecture tools, but my point is to get those people engaged at all, you have to use a sort of high-level, in my opinion, rather blunt set of tools, because what's powerful about connected health is once you get engaged, it's really sticky. Oh, geez, it's kind of fun to see my weights trended like that, and we're all a little narcissists inside, and looking at our data is kind of fun, but it's getting those people hooked, and getting them hooked is things like, well, you might want to pay attention to your premium, or if you don't check the box, we're going to enroll you anyway. It's tools like that.
All right, Shahid, do you have a counterpoint
I think
to that?
let's take some more questions.
Okay.
Yeah.
And by the way, they're agreeing a little bit too much, so the next question, please be hard-hitting. They're going to hold hands and sing Kumbaya in a minute. All right. Hard-hitting?
So, recent FDA guidance on mobile medical devices as mobile applications. What's the impact? Is it going to improve quality or stifle innovation, or both? And are you planning on registering your websites as medical devices and filing a PMA for them, or what's the plan?
I can go. So I was at the conference last month on that, and it's not going to be that bad in the sense of where all the websites, et cetera, will be become FDA devices. But what I did like about the general direction that the FDA took last month was in this exact area. They don't know. Right, and they said that. It's hard to hear that from the government sometimes, but so there's two ways of thinking about where they're going to go if they don't know. Either they're going to err on the side of regulating everything, or they're going to err on the side of regulating nothing. So they didn't pick either of those models, but what they did say is that they are currently reviewing the harm that can be produced. So they're looking for the safety part of the evidence that shows that if there's anything that can demonstrate that some harm can come, not just common sense and the good parts of it, but if they can see that some harm can come from some device, that they're likely to look at that as the first place. Just like with NIST, the National Institute of Standard and Technology, looking at EHR usability, instead of looking at whether or not the product is truly, quote, useful, can it do harm? And that's really, I think, where I'm more than happy to say as a technologist and a futurist and this and that, really that thing, the do no harm part is the most important to me, and that's where I would look for the most evidence.
It's a great question, and on this one, I'm quite ambivalent. A lot of what we've done over the years where we've made progress at our center has been by following the instinct on when to ask permission and forgiveness, right? So this is one where we now have to ask for forgiveness, or permission rather. So on the other hand, I saw for a couple of years a lot of stifling of innovation in the mobile health industry because people were kind of waiting. They didn't want to innovate on the iPhone because they were afraid that the phone would actually become a device, and who needed that? And Apple was holding people out of the store because they were worried that someone was going to try to regulate the iPhone. So at least we now know that the smartphone isn't going to be the regulated device, and that you can already see both good and bad. So there's already more people putting apps up for mobile now and deciding whether they want to go consumer or health. I think that's good. And right after that guidance came out, 3 or 4, and I'm a dermatologist, that's my avocation, right? But 3 or 4 apps came off because they were things like shine your iPhone on your face and it will help your acne. My God, that shouldn't be out there. So I think, you know, it's on balance better. Now, the last thing I'll just say is you mentioned the word quality. I would never in public say that I equate what the FDA does with quality, but it is what we have to deal with, and I think it's better than nothing.
Is there anybody from the FDA in this room? No, okay. All right, next hard-hitting question. Okay.
I'd like to push Dr. Kvedar on a point that you just made, that the lower costs that we're talking about and the quality that we're talking about are for chronic diseases. And I think that the current approach does little because I don't see that stickiness yet. That is, how do we avoid just like the shiny new thing, the ThighMaster phenomenon, where there are 16,000 medical apps available right now, and I don't see any cost curve being bent. So I wonder what we do to keep people engaged, that is, to have them use these tools long term to actually have some impact.
So if you don't know Jeff, you all should get to know him. He's a thinking ahead of the curve kind of guy, and it's a thinking ahead of the curve kind of question. And the fact of the matter is we're just starting to get a handle on that. It's early, and 5 years ago we were thrilled if we could show a difference over 3 or 6 months, right, and not worry about what we did over a year. So what we're seeing now, though, is it has to do with the way, it's two things really. One is the way you do your messaging to the individual keeps them coming back. So we do a lot with texting, and maybe this is obvious, but we discovered pretty early on that if you just send someone the same text every morning, they quit opening their phone. But if there's a little hook or a joke or something in there that brings them back, they keep coming back. So the messaging is a big part of it. I think what our friends at Healthrageous are doing is also the other thing, which is this dynamic personalization concept. Knowing so much about you from your data and what's coming into the system that we can do what Netflix, Pandora, and others do, except for healthcare, make it even better, will also be the tool that keeps people coming back. So we're not there yet, but we're getting there.
Yeah, and the other thing I would add there is that we need to keep thinking about, and it's a great question about bending the cost curve, because in the end, like I come from DC, so in DC, if you reduce the growth, it's the same as saving money. So I'm going to use that as an argument, is that if we could even do a dent on the growth, we're actually doing well too. But I would like to remind us that just because our patients are happier getting a text message and feel a little bit more engaged, in the same way that if we are more engaged with our airline right before we fly, it doesn't make the plane safer. It doesn't get us on the ground faster. It doesn't make us fly any faster. It's the things that we are looking for. And the reason why it's really important is to not gloss over these, because as builders of these systems, if we don't understand this and we don't inject these into our tool sets, we will do a failing to the rest of the society. So when we're looking at cost specifically, look at something like, for example, what Athena Health does with insurance models. They started about 15 years ago doing electronic billing in the cloud, before it was called the cloud. But today, they can actually give you reports on how well you treat per dollar in your area versus somebody down the street. Now, those are things that somebody had to think with some forethought, put it in, put the tracking in there, put the evidence material in there. Now, they were doing it specifically for cost because it's a billing system, but that doesn't mean that we, on the connected health side, if we're doing a connected medical device, if we're doing data transfer, we're doing health information exchanges, we have got to keep thinking that the quality numbers have to be inside those systems. The dollar figures associated with sending data back and forth and equating and trying to improve that engagement with the patient has to be in the systems. If we don't have them in the systems, we're all just going to be guessing for years to come.
Very much. I want to push a little bit harder on the evidence. I think what you've talked about is how there is evidence for subpopulations, patients who will use home monitoring for anticoagulation or your hypertension monitoring. But I'm actually interested in what happens to populations of patients. So for instance, in my practice, we have 6,000 patients with diabetes. What's the evidence that, in fact, deploying some self-management across that entire population will actually improve costs and quality?
Well, again, I alluded, so I'm not sure how I can better answer, so I'll just repeat myself and see if we can have a dialogue on it. So when I started this journey a few minutes ago, I alluded to our work with diabetes showing that patients who upload their glucose readings and have feedback from a nurse in a practice like yours have a 1.5 drop in A1C over 3 to 6 months that we've studied them. I think that's reasonable evidence to start. Now, you have to say, okay, if I apply that to 6,000 people, will it work? There's a leap of faith there. We've got to try it and see. But at least in that small sample, it was powerful, and so therefore we would say if we were able to approximate the same conditions in 6,000, we could get there. It's like Rudy Giuliani, his wife's calling. Yeah.
Cost and quality across the entire population. I really just mean to be, provocative.
Yeah, as you should be.
Yeah, and the question is, what do we have available to primary care doctors or to practices that we actually have evidence base for, that if we deploy, we can actually improve hemoglobin A1Cs across our entire practice. And I don't want you to do faith. I really want you to refer to evidence that shows us that deploying a specific self-management tool will actually reduce cost and improve quality across our practice.
The largest population that I know of in diabetes was the IdeaTel group, which was arguably not 100% self-management, but was a telehealth intervention applied somewhere between 5 and 10 years ago in New York. And with that, and I don't remember, it was thousands though, there was a significant lowering of A1C in that particular population. So I think the heart of your question is, as we alluded to earlier in the discussion, is the people who don't want to participate for whatever reason and getting them hooked. And I've already stated that that is still a challenge. We're thinking of ways to overcome that and applying them. But still, at a population level, there is evidence in diabetes that this kind of approach has worked.
Yeah, so the only thing I would add is that, and this goes back to the premise of because the evidence isn't there, it's incumbent upon us in our systems to put that in. So if we cannot say, for example, that if you have a 6,000 patient panel, if you were to do X, Y, and Z, there will be a 10% uptake in this particular period of time, and that's why you should go for it. That's why we're going to stay back, right? If we don't have enough evidence to provide predictors, not just evidence to show that it's worked in the past in this sub-element or that sub-element, until we have evidence that says, if you do this, here's how your value will grow, and this is how you will get an impact in some short period. Even if it's a year long, it's okay. I think if you knew, for example, here is a protocol, follow this protocol, use these tools, direct your patients in this way, and this is what we predict it will happen, that's real evidence, right? Everything else we're just talking about is it's generally background information to say, here's why you should try it. No, for skirting an issue, definitely, but give her the mic.
Skirting an issue, which is that word engagement, because it really does imply a behavioral component that none of us are talking about, although our first speaker alluded to it indirectly. People with dementia obviously can't be engaged, as our model for self-directed care would presume. So, and I don't work for Bosch, I don't know if anyone here does, but the Health Affairs study that was published, the pronounced difference between the engaged group of patients versus both the control and non-control group, both in terms of outcome and cost reduction, was astounding. And they deliberately measured, in this private study, not the CMS study, they measured engagement. They measured the behavioral stickiness that another speaker alluded to. So how can we get to that? You know, what about our model allows us to test for that and produce evidence around that?
So that's a wonderful question and lead in. I alluded to engagement several times. In our experience, it's really about feedback loops. And so the data coming in from whatever we're measuring about you, and it has to be objective, presented to you in the context of your lifestyle offers you the opportunity to have insight and to change behavior. The thing that lovely about being a provider organization is that we, most of us anyway, still feel a sort of special relationship with our care provider. And so when we know that, gosh, my doctor or a nurse in the practice is going to see that same information about my health, it does improve engagement. We have evidence of that, and we have evidence that when people think their doctor isn't watching, their engagement goes down. So it's both that knowing that you're being watched, it's a sentinel effect, improves engagement, but also that having access and you just keep getting this stream of information about you makes it top of mind. That improves engagement as well. So we have some clues anyway.
I'll just say 2 seconds on that, is that engagement, while great, doesn't necessarily direct adherence, nor does it direct behavioral change, which is what causes outcomes, which is what causes lower costs. Next question.
All right, we actually don't have time for a next question, but we do have time for each of you to make a 1-minute closing statement. Is that what you'd like to do now?
Sure.
Okay.
Sure. So in the end, I hope you got the sense that, while I'm not against the common sense part of this, the idea that there is evidence is not supported by the amount of literature that's talking in wide populations in a way, and this is very, very important, is, to me, evidence that has no predictive value in this particular instance isn't much evidence at all. So if we have evidence of something that someone is doing and it works well for that particular area of a region or something like that, that's not wide scale enough to be able to say that there is directed outcomes that we can see and directed cost savings, because I need to be able to say to everyone else and say, do this, and here's what I can predict could happen in your population. And without that, I think that we can pretty much assume that if the systems makers like us and the people who are buying these systems don't have those injected, we're never going to get the kind of evidence wide scale that we need to really make connected health work as well as we think it can.
Well, I hope I've been able to convince you that there indeed is evidence, and I've cited several bits of evidence from the literature and from our own experience at our center. And I would say that the sort of suggestion that it isn't enough evidence or that it's, we need to do more, of course we always need to refine our evidence, but we could also be tilting at windmills because when do we actually make the leap and try some of these things? And again, then it becomes the value. I love that idea. We're chasing value, or the eminence. I like both of those. So to me, the evidence is there, plenty of evidence to suggest that this is a fine approach that does improve quality. I would say that also, I was going to rebut this anyway, that indeed in our hands engagement is correlated with with higher quality and lower costs. So we've made that leap by our own estimation of our patient population. So I think that correlation is there as well.
All right, great. So now I'm going to reread the resolution and ask you to raise your hands again. How many in the room agree with that the current approaches to patient self-management do little to improve quality or lower costs? The next question, because we can't really tell. How many people actually changed their view as a result of this 1 hour? Really? One, two? Wait, which way did you guys go? To Joe. Which way did you go? To Joe? Which way did you go? All right. I thought there was another. Two. Okay. All right. Well, I do want to thank both Joe and Shahid, and I think this was, it may not have been a knockdown debate, but it was definitely an interesting discussion. I wish more of our national debates could be like this.
If you want to stay for the break, we're going to do our Rick Perry, Mitt Romney impersonation.
Thank you, everyone.